This is a general disclaimer. Redlands Community College attempts to have the most accurate and up-to-date information listed in its content and delivery. However, your education is your responsibility. Redlands Community College or Roy Smith makes no guarantee in the accuracy of this information in this video and accepts no liability for the informational video. The information expressed is strictly the opinion of the author and the presenter, which is listed in the reference near the end of the video. This information is designed to supplement your own education or initial education and should not be used to replace any current academic program you're enrolled in. View the information and content at your own risk. Thank you. This is going to be Chapter 13, Gastrointestinal Emergencies. An introduction. Various gastrointestinal emergencies may be encountered in the out-of-hospital setting. Gastrointestinal emergencies may include traumatic injuries and non-traumatic illnesses. Traumatic gastrointestinal injuries may include blunt or penetrating trauma. Traumatic gastrointestinal emergencies. Traumatic gastrointestinal emergencies require stabilization and rapid transport. These would be gunshot wounds, penetrating injuries, and things like this to the abdomen. Ensure airway. Ensure early IV access, limit palpitation, especially if it's an obvious injury. Ensure sterile covering of the open wounds, and manage the blood pressure carefully. Non-traumatic gastrointestinal emergencies. Most non-traumatic GI emergencies are also managed by stabilization and rapid transport to the hospital. And examples of these would be an aortic aneurysm, thoracic or abdominal, gastrointestinal bleeding, like a GI bleed, an appendicitis, pancreatitis, or peritonitis, inflammation of the tissue, generally bacterial, of the peritoneum. Pancreatitis would be number one cause of that, a gallstone, and a backup of the common bile duct. Some non-traumatic GI emergencies require medications, and examples of this include poisonings and overdose. And poisonings may require you to contact Poison Control Center for advice. It may require absorption of the poisons, and it may require control of vomiting for corrosives. Overdose may require antidotal medicine, and that would be to get ahead or to help the elimination of the poison, or it may require the induction of vomiting. An absorbent antidote, and this is going to be activated charcoal. Generic on this is primary care drug. Activated charcoal, and the trade is Actidose. Mechanism of action. Activated charcoal is a fine black powder that absorbs many drugs and chemicals. It acts by binding to toxic substances, thereby inhibiting the GI absorption, intrahepatic circulation, and thus bioavailability. It has a tremendous surface area, allowing for a large amount of absorption. The combined complex formed by the absorption process is excreted in the body and feces. It is a general-purpose emergency antidote in the treatment of poisonings by most drugs and chemicals: acetaminophen, aspirin, atropine, barbiturates, digitalis, phenytoin, propoxyphene, strychnine, tricyclic antidepressant, among many others. And this essentially just stops the absorption of the poison. On the adult dose, adults are 30 to 100 grams PO. Pediatric dose, infants less than a year, 1 gram per kilogram, and children 1 to 12 years, 1 to 2 grams per kilogram. Contraindication. Activated charcoal is contraindicated for treatment of poisonings by cyanide mineral acids, caustic alkalis, organic solvents, iron, ethanol, and methanol. Be aware when administering this to a patient that they must have an ample level of consciousness. They must be alert. They cannot have a decreasing LOC and you administer this. Activated charcoal in the lung tissue would not be a good thing. Pharmacokinetics, onset is immediate, and duration and half-life is unknown. That would be depending on your metabolism. Anticholinergic, antiemetic, and antihistamine. Most of our anticholinergic and antihistamine also have antiemetic effects, and this is an anti-vomiting effect. The drugs that we're going to talk about here are diphenhydramine, hydroxyzine, promethazine, and Zofran. Now, primarily the ones that we will be using as antiemetics will be Zofran, and the diphenhydramine is primarily used as an antihistamine in its case. We may see a lot of patients on hydroxyzine. It is used to assist and potentiate some of the effects of the antipsychotic medications that they may be taking. And promethazine is a good drug that people may be taking by prescription. Problem is an EMS in general, without a good medical history and without being able to see their medical history, it can cause an extrapyramidal symptom, and we'll talk about that a little bit. So first drug on the list is primary care, and the primary care on this drug is this does have antiemetic properties. However, we primarily use it as an antihistamine. Generic on this is diphenhydramine, and the trade name is Benadryl. Mechanism of action, significant CNS depressant. It has anticholinergic and antiemetic effects, antagonizes the effects of histamine and at the histamine receptor sites, and that's because it's an unadulterated histamine 1 and histamine 2 blocker. The adult dose given here is for anaphylaxis. However, half of this dose should work fine for an antiemetic in a pinch. Now, if the patient is vomiting and sick to their stomach and throwing up, the Benadryl at 12.5 to 25 should be ample as an antiemetic. Like I said, the dosing given here is for anaphylaxis. Adult dose of 12.5 to 25 milligrams IV or IM. In the pediatric dose, 0.5 to 1 milligram per kilogram IV. Generally, we'll do a 12.5 or 25 on them and cap it at some point. Follow your local protocol on this. Do not administer in either case any faster than about 25 milligrams per minute. It will have some untoward effects towards your patient. Contraindications for this is going to be hypersensitivity to diphenhydramine, acute asthma exacerbation, or lactation. Pharmacokinetics onset at 15 to 30 minutes, and duration is going to be 4 to 6 hours, and this is eliminated in the urine. Hydroxyzine, general knowledge, this is used in adjunct with many psychiatric medications. Hydroxyzine, trade name on this is going to be Atarax or Vistaril. Mechanism of action has antiemetic, anticholinergic, and antihistaminic effects. Acts as a CNS depressant. Promethazine as well, general knowledge. This has a high frequency of extrapyramidal symptoms, which will give us kind of like a dystonia, rigidity in the extremities, near paralysis. Mechanism of action, since it is a general knowledge drug, blocks the effects of histamine. Antiemetic effects are caused by inhibition of the chemoreceptor trigger zone. Affected motion sickness because of a central anticholinergic effect, and that's kind of what also can give us extrapyramidal symptoms, which inhibits the vestibular apparatus, the integrative vomiting center, and the chemoreceptor trigger zone. So the antidote, if someone does develop a dystonia or an extrapyramidal symptom with this, is going to be Benadryl. It's an allergic reaction that occurs in some people if you're giving Phenergan. And Ondansetron. Now, this is a primary care medication, and it works pretty well. Generic in this is going to be Ondansetron, and the trade name is going to be Zofran. Ondansetron reduces the activity of the vagus nerve, which activates the vomiting centers in the medulla oblongata. It also blocks serotonin receptors in the chemoreceptor trigger zone. Has little or no effect on vomiting caused by motion sickness, though. And the adult dose in this is going to be 2 to 4 milligrams IV push over 60 seconds. Pediatric dosing is going to be less than 2 years old. Is going to be 0.1 milligrams per kilogram with a max of 4 over about 60 seconds. Contraindication, known hypersensitivity to ondansetron. Current use with apomorphine, or apoquin, an anti-Parkinsonian drug. Used with caution in patients currently using medications which affect QT interval, procainamide, amiodarone, tricyclic antidepressants, or haloperidol. Pharmacokinetics is onset immediate and the duration is 2 hours, and this is eliminated in the urine. Conclusion. Very few gastrointestinal emergencies require drug treatment in the out-of-hospital setting. EMS providers should be familiar with drugs administered for poisonings, overdoses, and nausea and vomiting. This chapter has presented the common drugs used by EMS providers for these conditions. References for this has been taken from Beck's Pharmacology for EMS Providers, pages 192 to 125, Del Mar Learning. And if you have any questions concerning this chapter, feel free to give me a call. My name is Roy Smith, smith@imsa.net, or 405-219-7613. Thank you.